And this is now my pleasure to introduce Dr. Mirko Belliato from Pavia in Italy. He will talk about the improving of extracorporeal treatment and tolerance. Please, Mirko, the floor is yours.
Thank you so much, Mr. Chairman. It's a really a great pleasure to be and an honor to be here with you and with all the faculties. I have a quite challenging title because improving extracorporeal treatment is not so simple. So, sorry, this is my conflict of interest of the last 5 years. I would like to start with the questions. What we have to do for assure a total respiratory support during VV-ECMO, where there is no natural lung residual function. We need a very high performance system and remember that there is no cardiac support during VV-ECMO. So a question could be, could I use the VA-ECMO instead of VV-ECMO? The problems of VA-ECMO is the lungs perfusion because we skipped the pulmonary perfusion and just the lungs is fed by the bronchial artery. There is low blood saturation for the coronary artery and sometimes also for the brains. It depends by the performance of the native heart. And the distal limb perfusion is very critical. So we have high risk of distal embolization with this kind of configuration. Moreover, the VA-ECMO, if we applied a peripheral VA-ECMO, we can experience the Harlequin syndrome or north-south syndrome, in which the body of my patient is perfused by different type of blood that comes from the ECMO or comes from the heart and the injured lungs. So blue, that means blue blood from native lung or red blood from the ECMO. And it's quite difficult to understand which is the mixing zone of both. A potential solution could be the hybrid ECMO, such as venous ECMO. This support is used as a rescue therapy and involves both an arterial venous reinfusion cannula, inlet cannula. This mode of support is primarily used as an addition to an already existing ECMO configuration. The indication of this solution are patients with primary cardiac dysfunction or cardiogenic shock that have had hypoxic respiratory failure or differential hypoxemia, such as the north-south syndrome or Harlequin syndrome. And we need to add a venous returner cannula. At the opposite, we have patients supported, as in the case of ARDS, a severe patient with VV-ECMO, and develops cardiogenic shock and require an addition of an arterial return cannula for circulatory support or cardiac support both. When do we use the VA-ECMO in respiratory failure? For example, in patient with ARDS and biventricular cardiac failure, in patient with ARDS with left or right ventricular cardiac failure. This is important to detect which is the ventricle that is affected by low performance, or ARDS with severe septic shock. This last is a very challenging patient because probably the VA-ECMO is not enough. And when do we use the VA-ECMO in a cardiac failure patient? In patient with the post-cardiotomic heart failure with severe hypoxia, ECPR patient, this is quite typical, with lungs syndrome of ischemia reperfusion syndrome. That means a low blood gas exchange performance by the native lung. Cardiogenic shock patient with severe ARDS patient, right ventricle failure and hypoxemia, for example, the patient with pulmonary embolism. In this original article, it's described a single center experience and with this kind of a solution, and they treated patient with cardiac arrest, ECPR patient plus ARDS, patient with post-cardiotomic patient after CAD multi-vessel intervention with acute respiratory failure and unable to come off the cardiopulmonary bypass, or patient with refractory shock as hypertensive overdose and associated with acute respiratory failure, RDS, for inhalation, for toxic assumption of drugs, for example. The most simple switch from VV-ECMO to VV-ECMO is just to put a drainage cannula from the jugular vein and use both cannula in the femoral artery and femoral vein as inlet cannula.